Well, it's really great to see you. Thanks for joining. I have had a lot of experience in systems change, particularly in healthcare. So I'll use that as the case study. I don't know if all of you are healthcare professionals, but healthcare is always fascinating, whether you are or not. So hopefully you'll get something from it, because it is a complex and wicked system, always under the cosh and always being tried to molded and formed into something that's tame and linear when it certainly isn't. So, oops. Okay. All righty. So this is the sort of world of the NHS that the UK that we're living in. It's pretty similar around the world, though we have a really particular issue around the radical reduction in funding in the UK over the last few years. But as you can see, this is the sort of complex world that no one quite knows how to organise hospitals, and no one quite knows how to organise preventative services, and no one quite knows how to organise primary care. And then things pop up that no one had expected. So, our knife crime in the UK is shocking in some of our cities. So you can see youths assaulted with sharp objects up by almost 60%. So whilst everyone was planning apparently for older people to be our major problem, actually A&E is pointing in a different way at the moment. So this is the complex world of the NHS. And the problem that we have is that what the NHS experiences is that level of increased complexity. In fact, planning has never really worked because no one's done any fantastic modelling, and no one's really thought about the interdependency of institutions and organisations. So there's a level of increased complexity, but there's a huge desire to control and to seek simple solutions. People find that complexity makes them very anxious. And particularly if they're promoted to the top of the system as a result of expertise. So people rise up through bureaucratic public services based on their level of knowing something about their discipline, not their level of being able to be a systemic leader or to run and collaborate integrated systems. So finance directors become finance directors because they're really good at finance, rather than they're really, really good at boards and governing and facilitating and collaborating. Medical directors the same. So what we see is this phenomenal desire of a need to create certainty in uncertain environments. And I think in health services, that's very, very particular because of the nature of the game, which is that people's lives are at risk. And so people feel even more phenomenally responsible around quality and safety. And that need for certainty, given that there are so many unknowables about the care of people who are critically ill, that certainty seems to be a sort of very, very particular driver particularly in health services. And in the NHS in the UK, the experience is primarily transactional cultures. But of course, what the NHS needs is an adaptive capability. It needs creative solutions. It needs different sorts of resources. It needs to be able to experiment, and it requires leadership through relational culture. But what you see in terms of what people need in adaptive systems, if you're going to try things out, then trying things out has the risk of failure. And so in a critical system like health, people are very, very scared of that. So we've got this duality going on all the time in the NHS, the need for an adaptive solution, but the tendency towards a linear cause and effect. And you know the world is moving from this individual hierarchy, consumerism model, right through to a much more collaborative network model. And in fact, most of the ways corporates organise and public and voluntary sectors organise, it's an absolute move towards a networked type of organisation where you have partners and alliances, whether joint ventures, whether subcontractors. It's a much more complicated world in terms of relationships, but much, much more focused on need. So networks are fabulous places because they're creative. They generate many, many more resources than hierarchies do. They're really good at finding new solutions to old problems, but they are peer-based and they're distributed and they're not hierarchical, and therefore who's in charge and who should get paid more than anybody else is always a different sort of challenge in a network. But we are seeing in health services around the world this move to a more network and collaborative model for health systems innovation. And that requires a whole different way of organising. And in the health service at the moment, we've been trying to do this in primary care. And what we're seeing is primary care networks. These are groups of GP practices collaborating together particularly around acuity of people with complex needs that can't be met in primary care in general practices. But what happens is that the top of the system, NHS England, keeps using that hierarchical model the whole time to try and manage. And most of that is around trust and mistrust. That if in distributed models, those at the front line haven't innovated to solve complex needs, then the top of the system doesn't trust them to be able to do that, and hasn't realized that the way it has infantilized the front line through its lack of trust and through its performance management has really got in the way of people being able to organize collaboratively and take responsibility for themselves. So we're in that transition mode, in this transition here. And the transition is challenging because you have the old world biting back and the new world trying to emerge. And we're seeing that, I think, throughout. But the new world is definitely emerging and is definitely having more dominance than in the NHS at the moment. The contracts for those primary care networks, so there's been a new set of them over Christmas, there's been a real pushback from these collaborative networks saying, if we do that, it will stifle our ability to solve the needs of people who are acutely ill with very complex needs. And this is why. And there's a much stronger sense within those networks of their own efficacy, of their own responsibility, and what they need to do the job. So you can see this sort of birthing of networks in health services. And you see that, again, around the world. We've seen this intermediate tier in primary care beginning to develop around acuity based on a collaborative model. Some of this is a trajectory. You might have seen this, a really nice Reinventing Organizations book, but you've seen this trajectory of sort of going from the early years of man as they identify it around wolf packs and some of that evident in our current infrastructure. Gangs is probably a good way, a good example, through to a hierarchical model in the UK, probably very still predominant in the Catholic Church and public schools. Into the orange model, which they talk about trying to a target-ridden culture. How doesn't matter so much, but expectations, very, very clear objectives. A metaphor is the machine. Everybody does their part, the whole hangs together. Walmart being a good example. Through to a sort of more family-orientated relational model of organizing, culture and empowerment. Really, really thinking about the nature of relationships. Sometimes has all the dysfunctional elements of families if it's purely based on relationships. Ben and Jenny's is the usual example people know about. But now moving into the sort of generation of what Lalu talks about in terms of teal organizations, which are around self-organizing teams. And these are, adaptive systemic ways of organizing. Very, very clear about purpose, why we're in it together, knowing whether we've achieved it, what feedback loops we've got about how well we're doing, organizing around that purpose, peer-based review to ensure that as members of the network generate and undertake work, that it fits in with the purpose, real levels of accountability across the network, very, very good intelligence systems, very good knowledge management systems to enable those subgroups to be able to do the best work on behalf of the whole. But the feedback loops being absolutely critical in teal organizations. I don't know where if you're watching this, where you think your organization fits. When I ask people in the NHS, they sort of say they're a mixture of amber, orange, and some emerging green. The third sector seems to think it's more green. And we don't see much in the way of teal. A good example in the health world is Bert's in the Netherlands. Worth having a look if you don't know it well at the moment. So the base of most of our planning in health systems has really been that the environment can be simplified enough to be modeled into a limited number of variables. And if you look at things like smoking, the predominant model to deal with smoking is smoking cessation classes. And there's still, in the UK, there's still a really big push to have smoking cessation taught in outpatients and A&E. And now if you know Michael Marmot's marvellous work, and you might know his story of standing outside a working men's club in the north of England, and there was a guy who was probably my age smoking and drinking, and he said, "Do you realize that will kill you?" And the guy who was smoking and drinking said, "Why would you want to live here?" So no idea of smoking cessation is going to solve that man's problems, because his problems were poverty. So if we if we take these simplified models, we come up with very simplified solutions. And if you reduce the variables, you don't then handle the sort of dynamics of the major issues. And I think in the UK, our ability to walk away from poverty as our major cause of ill health is phenomenal. And we're amazing at how we can both deny that and ignore it. And partly because we do this. There's then a sense that the environment will stay constant such that variables stay the same, which is why planning for old people completely missed the issue around knife crime for young people. And that the system is predictable, whereas we know it's non-deterministic, it's entirely unpredictable about how it responds to variables where it requires adaptive response. So no matter what the feedback loops are telling it, no matter what's going on internally, the system itself is always, the general model is X always equals Y. You just need to do this. The smoking cessation will stop people smoking, and that will therefore ensure that we have less smoking. The examples I'm going to share with you later on, that A&E is a very good one, which is that people are coming to A&E because primary care is not offering enough appointments, not borne out with a huge amount of data, but it's a really nice linear relationship. And so what do? You offer more GP appointments, and that will solve the problem. And of course it doesn't, because they haven't really understood the problem in the first place. So the problem with the simple solutions is it generates an increase in the problem. Back to the A&E example. Okay, so the current solutions increase appointments. I just talked to you about that. But the problem is that increases demand in primary care. So if you increase the appointment system without understanding need and without working with communities to work out what solutions might be, just putting in more appointments when people have nowhere else to go, particularly people who are struggling with life and in a level of poverty, just means that means that more people go, and actually it's done. This is done in a model in the UK where no one knows how many appointments anybody should have. Practices vary enormously with the same populations. Neither does anybody know how many people are being turned away or where they've gone. So if you don't understand what's really going on now and you just lop in more appointments, no one really knows. So what's the real problem behind people turning up in A&E, or primarily in the UK number of people waiting in A&E? Well, one of the issues is that there's more complexity in A&E. And when you ask people at the front line of A&E, they'll say, well, actually the people coming into A&E should be here because they're really ill. But the solution to that is therefore not more primary care appointments, because if they're really ill, a GP can't solve those problems. But what might solve the problem of more complex folk in A&E, and mostly, whilst we've got an increase in knife crime in cities, most of our A&E in the UK at the moment is people who've got comorbidities and complex needs. So complex needs need sophisticated interventions. So having a junior doctor at the front line of A&E is going to lead to more tests and to more people being admitted. So the solution has to be put senior clinicians on the front door, change the skill mix. This is not a trauma service now, not primarily a trauma service. It's now a complex care service and a trauma service, and we haven't rethought A&E. So if you look at the evidence base, and this is a very nice study, it says that our A&E waits, the waiting times, they call them breaches in the UK, you're not supposed to wait more than 4 hours in A&E, are because we've got increasing acuity. There's an increased length of stay within hospitals, and that's because we haven't got enough staff walk around a hospital in the UK. At weekends, it's barren of staff in the general wards. Staffing of facilities out of pace with the changes in needs in A&E, and there's an increase in case management. So people order many, many more tests in A&E. So it's much more complex than saying people couldn't get an appointment in primary care. There's a real change of dynamic in A&E, and the systemic response is to understand that and bring the system together to solve it. But the linear response is, of course, to pick a nice simple solution and go after that in the hope that it'll solve the problem. And this is because I don't find many senior leaders in health really understand what type of problem and what type of solution. So we tend to work with leaders and say, there are 3 ways you can tackle the problems in front of you. Some problems, you just need to do them well. And they're the sort of basics. They are the linear cause and effect, the stuff that's amenable to hierarchies. You might be able to think about them. Car parking is always a good one. But there are payroll. These are really great ones that are absolutely linear. But and that takes that mechanistic response, but there's very, very little in the health sector that's linear. There are some things where we want to do better. We're sort of doing the right thing, but we need to improve it. The citizen feedback isn't great, or there are better ways of doing that. Increase productivity, maybe increase value, maybe shorten people's length of stay, improve quality. And those are things we need to do better, and their participation requires some incremental improvement. But the health system will not be changed by incremental improvement. There are some things where we are responsible as clinical professionals and as managers, and that we want feedback, and we absolutely need to involve citizens in the change process, but it's more of a pathway issue. And then there's the do better things, and I would stick accidents and emergency into that. We have got the wrong solution for the problem. And this is a relational co-produced solution. You need the system in the room to do it. And so helping boards and senior leaders understand the problem in front of you. Is it something that you should just do well? Is it something you should do better? Or is it something where you need to do better things? And that means we've got to come up with different and alternative ways of both understanding the problem and finding the solution. So you might want to have a little think about whether that model is useful for you in terms of just beginning to differentiate. And of course, most problems have elements of all of those things to it. If you're dealing with people who are living with dementia, then there may be some things that are mechanistic that you just want fixing, rails or things to stop people for sloppy slippers. How do you help people just have the right shoes, take the sloppy slippers away and put something useful in front of them? That's fairly mechanistic. What things might you do better, and what things do you need to do very, very differently? And so trying to understand that for every single issue, there's probably an element of both is helpful, but having categories to differentiate might encourage people to take that more interrelated systemic view of the problem. Now, the next issue is understanding what a system is. So when we talk to people about having a systemic response or leading a system, people tend to see it as just their organization. So, of course, Sengi has a really lovely example of what a system is. So a perceived whole, elements hang together, continuously affect each other over time, operate towards a common purpose. So if you think that as a general practitioner running a primary care facility, that I can look after people when they're poorly to a certain level, but then at some point I'm going to need social care, third sectors, families and friends. I'm going to need other people. So me seeing somebody in an appointment isn't going to solve this person's problem, because it's interdependent on so many other people helping out. So those are that. So what's the system for this person around this particular issue that they're presenting with at the moment? Be that a struggling with a life poverty related issue that means they can't manage their health, or whether it's a complex health need. So young women who are self-harming, can a GP handle that on their own? Can a one-to-one appointment handle that on their own? It's very, very unlikely. So what's the common purpose that where we've got some skin in the game, and who else needs to be the system? And I'm going to show you some examples in a minute, but we're talking about being interdependent, and the whole for that system is different. If I do my part, it won't make the whole better. We have to have everybody trying to rethink what the whole is, organizing around some shared principles about the relationships. So taking the young woman that's self-harming, if the whole system isn't responding in some sort of way with some shared principles about what it takes to intervene with young women like that, then you're going to have some conflict for that person to try and navigate themselves. So what we know about systems innovation is it requires curiosity, it requires a question that you're trying to solve together, it requires the folks who are involved in that question, it requires some level of exploration, curiosity and testing, it requires people to learn together, and it has to be based on data on what's going on here and now. A colleague of mine says you can't get there from not here. In any system change, you need to start with what's really going on now. I'm going to use an example called Co-Producing Leads. It's in 2011, and I'm using this one because it's lasted over time. So not only was it a great experience doing it, but question, and you have to find out what's the problem, because what you see determines what you do. And I like this a stick in the I don't know, the little boy with a boater hat on, what Jen, In our generation, sticks are for fighting and shooting people, probably an element of both in both, but how you see the issue determines what your solution is and how you respond to it. And some of that is cultural and set by a level of norms and principles about what we're here for. So if you look at the founding of the NHS in the UK, there were some key principles about the NHS that sort of underpin why it's stuck in its hierarchical model. And can do, should do, doing means treatment, treatment means cure, I am responsible. So it was set up in a very paternalistic model with professional expertise. The NHS was there to cure, not to care. Now, if you look at some of the current models with our more capitalist governments at the moment, then there are some interesting other norms now generated around principles of the NHS. Some of the outcomes can be easily measured. I wish if only. Human services are like manufacturing processes. Everybody does their bit and it all adds up. Professionals always resist change. Citizens are too demanding. But if you look at high-performing health systems around the world, actually they've got a very different set of guiding principles to how they organise. They understand people as owners, and that if you partner with people as owners, then people will step up and actually both have a say, but also co-generate solutions. That it's not I'm responsible, it's we're responsible. You do what matters to people and demand drops because people's health is contextual. So rather than us determining what's right, we find out from citizens what they think they need and what's right. So health is relational. You need real-time data and you need to meet rather than manage demand. So if you look at Bertzold, Alaska, Jönköping, Intermountain, they're taking these types of principles, maybe not all looking like this, as their founding guidance for how you design a systemic way of organizing healthcare. So how you see the problem, the founding of the NHS is that it's about curing illness. It still is that. In high performing systems, it's about generating relationships so that we can find answers together for complex needs. Those are very, very different starting points. Here's an example from primary care. When we ask our GPs, this is some practices in London, about if the person in front of you a GP appointment, we found that the GP said it wasn't something they could solve. That's phenomenal. But yet, interestingly enough, they were turning away 15 to 20% of people at reception. They couldn't get an appointment on the day. Now, they didn't know that. So their view was that we're seeing everybody that we can't meet demand, demand's rising, it's unsolvable. And you say, well, actually, if you're not seeing the right people, why are you offering appointments like that? Because if you can't meet their need, then something else needs to happen. And look, how fascinating. The 40% is bigger than the 15%. So maybe the 15%, there's people waiting there that you're turning away that really do need to see a GP. Do you see what I mean? One of the things we found is that people use a level of sort of previous assumptions, stories, myths, power dynamics, say this is what I believe and I know because I have the experience, and it gets reaffirmed and reaffirmed and reaffirmed, rather than grounding the issue and what's really, really going on around here. So if you're going to start solving any systems problem, one of the things you've got to do is work out what the problem is, rather than take at face value the problem as presented, because that's a symptom, not a cause. Here's another one. I asked the GP to do a deep dive on a lady's records to say how many times had she touched a health service in the NHS over the last 2 years. Year one wasn't so bad, this was year two. Now, year two, and this was without the GP adding his appointments in, this was community service and hospital service, that's phenomenal. He had no idea that lady had seen that many people over that year, absolutely no idea. He just had his appointments. He only knew his bit. And so he could only act on his bit. That isn't going to solve that person's problems, and clearly doesn't, because that person is bouncing around the system with nobody understanding the frequency and the nature of how often that person's presenting in A&E. And behind that must be a fragmented and fractured and exhausted family, let alone the person themselves. I like Myron Rogers' way of getting in systems problems. He first says, what's the problem? So how do we know? And then what's the system for this problem? Can the system access itself? And what wants to happen? I'm going to show you how we use those questions in trying to revolutionize drug and alcohol services and leads through co-producing leads. And I've begun to show you that people don't really understand what the problem is. So they take this surface problem, which is usually a symptom, not a cause. So let's start with causes when we're looking at systemic issues first. We found some ways of getting into what the problem is. We've asked people to, this is a colleague of mine, Nick, who works with me. We ask people to do case study histories. We try and undertake some citizen dialogue, or encourage people to do that. Bring in your experience, but it's not the only part. Generate some evidence packs, maybe some deep data reviews, some dives, maybe trying to understand the pattern of attendance or the pattern of the service. Do some good data reviews, having a look at Deming's SPK, just to give a sense of, you try and gather some intelligence about what's going on. Take your hypothesis. This is my hypothesis about what's happening in the system. We could take that one about people turning up in A&E because there aren't enough GP appointments. Let's take that hypothesis. How is that reinforced? It's reinforced because that's what's in the papers. And then when some people ask some people at A&E, why have you turned up? Say, I couldn't get a GP appointment, because they're terrified and they know that's the only way they can get through the front door sometimes of the A&E. And then it feels a legitimate reason because that's the one that's in the papers. Not because I'm scared to life for my kids. And I think you're going to think I'm a bad decision maker because my kids got some spots, or I couldn't afford the bus to the GP, or I'm worried, or whatever it might be. Why are people there? Not necessarily from what they actually say. Let's have a look. Let's try and find out what's going on. So when you're talking about a systemic issue, the first thing you want to do is find out what's going on around here. Let's talk about co-producing leads. So this was a group of us in the city who wanted to put together, well, we wanted to have a go at trying to co-produce something, to be perfectly honest. And it was myself working in the university. It was a number of citizens. It was some third sectors and some NHS organisations. Of people who had drug and alcohol dependency in their city. And we were stepping over homeless people in the street who were clearly not being supported well. So we didn't really know what the problem was, but we know that we had a sort of an assumption. Our first assumption was we could do better, and Liverpool seems to have a better answer to it than we do. And what we found when we did a deep dive into what the problem was, by asking, and we surfaced that by those of us involved in the sort of design group, just going out in whatever way we could to interrogate the data and find out what was happening. And when we put the data together, data from the council, from the health service, from our citizen members of the design group talking to other citizens, we did a really sort of rough and ready but good enough dive into what was going on. One of the things that came up was this over-reliance on main self-destruct. We thought we did a bit more work on the quality, and we found it was worse than others. There was very little citizen participation in leads on their journey. And we weren't differentiating the service by type. So older folks who had an alcohol dependency, some parts of the leads, it was a mystery. You know, so hang on a second, you know, these are really old people. They're in their 70s, 80s, but they have a dependency on alcohol, and they're not even being seen as alcoholics in there, because alcoholics are people on the street who were drinking out of paper bags. You know, that how you see the problem determines what you do. So we found the problem was more nuanced than the city had understood it. And the health professionals were furious with us about it, and they demanded to see us, and sort of turned up in their droves to tell us how terrible it was and that they were running a fabulous service. And at that time, in terms of commissioned drug and alcohol services, they were way down the priority list. And we said, well, you know, if you're doing such a fabulous service and yet you want more, and you say you're not having enough funding and you're way down the priority list, this maybe surface what the issues are, and maybe we could have a better drug and alcohol service in the city. Anyway, I will tell you the story as we go along. So find out what's really going on around here. And this is what our citizens said about us. So they said, you know, involve us. Be honest. It's okay to say when things aren't working. You're real humans. We know you're doing your best. This is not a judgment call. This is, we think we could do things better together. You know, And what about sometimes the way you do your best is because you do it in a way that you understand. This is how professionals work. So why don't we have a better conversation between us? Because actually we've got ideas about that. And then they said, don't promise what you can't deliver. So they wanted a level of honesty and they wanted a level of involvement, but that's what service users said. Okay, so maybe you can start thinking about a systemic issue and whether you think you really know the causes to that issue, because systems leadership is about taking those systemic issues and trying to find collaborative solutions. So let's go back to our co-producing leads. So what's the system for the people who are dependent on drug and alcohol? So when we've begun to say we've got a problem here we don't quite understand, but it's not nuanced, and people aren't getting services the way we think they should do. Systems don't feel involved in those services. It's a maintenance service, and it's not differentiated by need. So what will be the system for that problem? And we sort of mapped it out. It wasn't as neat as this. But as a design group, we then say, so who are they? Well, obviously there's health, and then there's real families, and then there's social care, and then there's housing, and then there's faith communities, and then there's the retailers who sell drug and alcohol, and then there's the gangs that sell the drugs, and then there's the police, and you can think of more. So we mapped them, and I couldn't find a diagram that would differentiate it differently, but we said how much of a say or how big a service, you could have third sectors into that, how big a service, what proportion, if this was 100% and we were trying to map everybody involved, what percentage of involvement does health have? What percentage of involvement does the police have? Well, health had a bigger chunk of the pie than police had. The retailers had a bit of a chunk of the pie, but not very big. Faith communities a little bit, social care loads, families huge. So we tried to work out, if that was the 100% circle, what percentage did each of those organizations or interests have in designing and delivering services for people and with people of drug and alcohol needs. And of course, we have to include service users as well. We made a decision that we were going to get this system in the room. So once the system has access, once it knows itself, it can do something about it. Let's get the system in the room. However, if that is the design system, feels undesigned, but there was a level of design to it. It was getting the outcomes that we were getting, which was not good enough. If we're going to get folks in the room, then at least half of the people in the room must be people who are using drug and alcohol services. So we decided that we'd map that system, knowing that when we get everyone in the room, half of the people in the room have to be users of the service. And we started mapping it like this. So we took health and then we started pulling that apart. Do we mean mental health? Do we mean community services? Do we mean A&E? We meant all of those. In mental health, what's the organisation for it? What professionals would we want to see? Well, we'd want to see a doctor, psychiatric nurse, we want a manager in the room. And then we want to make sure we've got a mixture of top, middles and bottoms. So when you're talking about the system, you really need to map out granular detail what the system is, because when you want to get the system together, you need folks from all those parts of the system. You need people who are frontline, middles and tops from across all the organisations that are involved in the room. Now, if we haven't got enough places in our event for 3 people from mental health, we might need to take a senior manager from another service, but we need senior management in the room. So across the health service, we need some senior management, which organisations they're going to come from, because of course we also wanted A&E there. We also wanted community services. We also wanted GPs. So when we did that list, we came up with hundreds. And we thought, well, what's going to be a reasonable representation? And representation is the wrong word, because people can't represent anybody else. What you're trying to do is put the system in the room together so that people can be themselves, so that you have some sense of this is what the system looks like when it's trying to work. So we ended up with an invite list of 200 people, 110 of which were citizens. And in order to invite people to this event, I'm going to show you a video in a minute. I hope this will work. Josh, you need to just help me with this. In order to run this event, we had to go invite people personally. So I asked colleagues who are working with us to go and find those communities where people were living with drug and alcohol who may or may not be using service. And they said, well, the best thing to do is to get the taxi drivers who pick people up from prisons and see where they drop them off. So that's what they did. They asked them and they went to those places and they hung out in cafes and they invited people to this event. And we ran a precursor event for the citizens who wanted to come so they could at least have a run through of what was going on, because they're not used to these sorts of events, whereas professionals always are. And then we ran between us, we personally invited every single other person and there were no substitutes. But what you will have seen is 200 people coming together in the town hall in Leeds. And we started with context and people telling stories. And what we found was that the professionals really, really struggled to engage with citizens. We had round tables, it was set up like a cafe. There was a space at the back for people who were struggling to be able to just exit if they needed to talk to somebody. We had the police around the town hall because, of course, if we have people with drug and alcohol in the town hall, then the drug sellers were going to be and gangs were going to be circling the town hall trying to sell drugs. So we put in the sort of, obviously, the safeguards, personal safeguards that you needed. And we had a lovely guy, and we ran it with people who had drug and alcohol problems. At the front of the door, there's a lovely story of a lady who worked at the town hall. And she was going, oh my goodness, what's happening? All these people, it's terrible. We're letting all these homeless people in, etc. And at the very end of the day, she was working with a chap called George, who was in a suit, and he said to her, I'm homeless and I'm going back to live in a tent around the back of the town hall later. And she was absolutely amazed and had no idea. And so what we found at the event was, as we encouraged and enabled our professionals to integrate well and sit and tell stories with citizens, that there was some absolutely amazing results that came out of it. And what happened is that we set up a number of things in the city. We set up a social campaign. We started differentiated commissioning mini events across different parts of the city so that people who were older drinkers were getting services. And what generated out of that event was a peer network of 50 citizens who were living with drug and alcohol dependency, who decided to support both each other, but all the services across the city. So we tested out an alcohol-free bar. There was just a whole thread of new events that we ran as a community of practice across the city, 70 of us going from that event into the doing phase. And so solving housing, beginning to solve all sorts of problems together. So what happened, we had a whole different group of people now leading drug and alcohol services in the city. There was a new energy in the council, a huge citizen group themselves, different people emerging within primary care, and the service improved fairly dramatically. Now, when you look at what happens in collaborative spaces, people do this where there's a history of collaboration, where citizens are part of the diagnosis, where there's time to learn together, the system leaders don't get distracted, and there's some startup funding. Now, we had £70,000, not very much, over 2 years to support this, but we came together regularly, having lunch, all of us together, saying, what are we learning? What can we do together? So having worked out, having put the system in touch with each other, you sort of have to say, well, what's the system want to do? And what the system wants to do is, it sometimes is supported by the old forces, and sometimes isn't. What got in the way was how difficult it was for us to data share. The process for decision making across partners was complicated. We were worried about setting expectations too high. Sometimes some of the partners didn't feel like they owned the solution because they hadn't come to the event. There's a lack of experience in working with citizens. There's a real vacancy of support at the centre. And what we find culturally in the UK, these things were sort of endemic across the whole. We're really behind on data, and citizen participation doesn't happen. So when we talk about systems leadership, you really, really can't do it without citizens being present. And you have to generate some level of frustration. What we did with co-producing leaders, make it untenable for everybody to stick with the status quo by being very public about how much worse we were than Liverpool, to be perfectly honest. And we had to really diversify who was involved. Now, what happened over time, the sustainability of this was some years later. And what we saw was that you could see this whole set of folks turning up in Leeds and setting up a tent city, and it was homeless people in the city, apparently. Now, that was really, really worrying. You can see that top left-hand corner, there were 80 tents that suddenly sprung up over the course of 2 days, really campaigning about the lack of housing in the city. Now, our peer group from co-producing Leeds, and this was like 4 years later, were horrified to see this. They went to talk to the council and said, hang on a second, this isn't quite right. Some of these people we know, they're long-term homeless. Other people seem to have come in from other places. Some people have got really legitimate problems, but this isn't a safe way to do it. So what they did was they asked the council to provide a different space, and down the bottom you can see there's a square. So the council moved all these tents into this square, not saying they're going to deny the problem, but they wanted it to be safe. And our peer group from Co-Producing Leeds set up the cordon around it. You see that nice yellow tent. And what they did was they registered everybody, because they said this gang of people in these tents are going to become victims. They're not stable, they're vulnerable people. They'll be victims to paedophiles and to criminals. And so we have to protect those people as best we can. So we will volunteer and set up both a registration and a marshalling system. And we will then work with, and at one point it involved taking the council to court, but we will work to find solutions for these people. And within the space of 2 weeks, they cleared all those folks either into homes or into some level of safe and secure support for those that really, really didn't want homes. And it was absolutely amazing. Now, that wouldn't have happened if we hadn't had Co-Producing Leeds all those years earlier, and that peer support network, and people feeling they could step into a problem because they saw that problem as their problem, as part of the system in Leeds. So we're thinking about talking about systems leadership. You've got to really deal with volatility, uncertainty, and ambiguity. And that's what we found in Co-Producing Leeds. It was the uncertainty of the future that made people hang on to the rigid old, but also it was the chaotic nature of the citizens they thought they would have to engage with, who they saw as patients with a level of dependency rather than people with assets. And once we turned that around, so these are people with assets who happen to have difficult and traumatic lives, who want a different sort of solution, we managed to generate that better solution together. So usually when we're talking about systems leadership, it's place-based. Usually it has an issue associated with it. We talk leads, we talk drug and alcohol services, and it's usually about a shared purpose. And ours was, what could we collaboratively do better to enable people living with drug and alcohol services to have better lives? So there's a critical role in systems leadership, and I think that's about making sure that we've got clear expectations, making sure you understand the context. I talked to you about starting with what is, making sure that we're congruent with our purpose and values, question the underlying assumptions that govern the system's action system. That was our job as a design team. What's really going on around it, and why is it like that? And what we found was the maintenance system suited some professionals, and in some ways it enhanced their standing, but it didn't solve the problems. You've got to make sure that the system can adapt. So how do you generate the relationships and support those for that to happen? You have to bring in diverse people. You have to do this as peers. So we tried to model that in Co-Producing Leeds as a leadership community. You've got to let go of that desire to oversimplify, and you've got to work with the mess and emergence. We would never be able to predict that response to Tent City. Neither would we be able to predict the outcome of Co-Producing Leeds, that we were going to have this differentiated commissioning service, that we were going to have that peer. We didn't know what the solutions were. We just knew they would emerge. And that for me was really important. And the principles of the event underpinned and allowed that emergence to happen. So our key values, talk about purpose and clear expectations, were everybody should have an equal voice. Everybody has something to offer. Everybody has something that they need. And some of those principles underpin the design that you can watch on YouTube, and how we ran the event, but also how we then set up all the relationships afterwards. So those really, really matter if you're going to expect emergence to occur. So the systems, the capability of systems leaders, you've got to be able to work at the whole system, but help and encourage people to get there. You've got to be able to step into each other's shoes and see these diverse players' viewpoints and encourage them to be open. You've got to listen, start. Everyone said with Co-Producing, these are my experience systems leadership, is you have to start with listening. It's not start with telling. Trust isn't something that's built out of broadcasting. You have to be able to work with the emergent approach. There has to be learning, and you have to generate this long-term and short-term value creation. So what we found was that when we looked at all the things we wanted to do, there were some things that were much, much longer term, and we had to sustain our interest in them, and some things that were quick wins and short term. And funnily enough, setting up the dry bar was a sort of indicator that we were changing attitudes in Leeds. It lasted for a year. We had some great pop-ups and some enormous fun. But it was it was trying to demonstrate there's a culture change going on in the city, a little short-term win. Okay. So when you look at the character of systems leaders, the sorts of people that can do it very well, these are people who are very confident in their own ability to work with diverse people, but they have some sense of the future. It's that, how do you help people manage ambiguity in an uncertain world through some level of certainty? And the certainty the systems leader's job is to hold that sense that don't worry, there is a direction here. This is the direction, absolutely confident that we'll get there together, etc. But the other feature, I think, of systems leaders is you have to be able to give up territory for the common good. And when we were working co-producing Leeds, the biggest fear was that people were going to have to cede territory, that I was going to have to give up my bit. We use the same model in Leeds around domestic violence and people who have very traumatic family situations. And again, people got into that model of being able to give up territory in order to work better together. So it was really great to see that. The things to watch out for, I know we're just sort of nearing our time now, things to watch out for is the old world biting back, that culture eats strategy for breakfast. And these things ebb and flow. What I found has been a real joy, particularly because of our work in co-producing Leeds, is seeing how those elements have just trickled through continuously over time. So whilst the old world bites back and people try and do things in the old way, and you can see evidence of that all the time, look for the evidence where people are trying to do things in the new way. We found that people who had been at that event, there were a significant number who were really touched by that and the ongoing work. It changed who they were, it changed how they did their work. And they then took up leadership roles in the city. And that was fantastic to see. But it really does. Culture is, the dominance of that hierarchical model is endemic and so you have to really stick in it for the long term. This tendency to turn wicked problems into tame, it's a phenomenal draw. It makes people feel so comfortable, and that's really important. Tendency to structure as a hierarchy than a network. People like hierarchies. They know where they sit. They know that they get paid more for being at the top of it. Networks feels dangerous. It doesn't feel like my voice is heard as well. It feels messy. It takes time. It doesn't feel as clear sometimes, and people struggle to work in that world of networks, particularly if generating equal peer relationships is not their cup of tea. And finally, a reminder. So watch out for the old world biting back, but a reminder that all of this work is relational as you're doing systemic leadership work. The less time you spend on relationships, the less time you have to generate possibilities, the less time you have to then plan those and put those into action. Your relationships take time. The more you know people, the more diverse people involved, the more possibilities that emerge, the more you can plan for the future together, the more you can take action that sticks. And that was our experience. I hope that was helpful. I'm really, really sorry about the video mess up. I hope you get a chance to see it.
Great. Thank you very much, Becky. That was awesome. You touched upon a lot of points there. So we've got a few questions from Twitter. We'll just go over those now. I think your first point about people rising up in the hierarchy based upon their capacity to do financing or particular activities as opposed to complexity, right? That's a great point, isn't it? We don't really, and all those aspects of systems leadership that you mentioned at the end there, dealing with ambiguity and creating space for other people, they aren't really the characteristics that get selected for and promoted for, exactly as you say. So one question or kind of one comment there was about, you touched upon it a few times around the desire for control that hierarchies give, and that actually, I think that kind of is connected to people wanting simple solutions, isn't it? It's that say policymakers or the public in general, they kind of want silver bullet, simple solutions, and they want people in control to kind of deliver those solutions for them now. And that's a big part of what kind of reinforces that linear approach. So that was more of a comment. There's a question: do you see many people kind of out there talking about networks in healthcare?
Yeah, that's right. So a couple of things, which is, the system's always perfectly designed to do what it gets. So when things go wrong, it's really, really hard. I was reading a really great piece from Joseph Rowntree Foundation about poverty. And they were saying, people are tired of the facts that there's more poverty. And so it's really hard when you say you have to start from the status quo. And people go, I don't really like that. We're nice people. We're a first world country. What do you mean there's more poverty? I mean, they must just be lazy, rather than it's just, if you just don't want to pay more taxes. The ability to duck and dive around the stuff that we don't like confronting and we find uncomfortable. And some of that, the Roundtree Foundation was saying, it's how you use language and how do you help build a sort of better future out of the current situation. And I think the use of language is a really important skill set for systems leaders, which is, how do we, for instance, around poverty, how do we take people's compassion? Not just we're a civilized country, but, isn't it terrible that some folks are stuck in poverty no matter how hard they try? And that's quite a different framing from, oh my God, you're not prepared to vote for anybody that'll raise your taxes, and so therefore it's your fault, these folks are in poverty. It's very interesting, just shifting, how do you help people climb out of that simplistic world into a more complex world through the invitation of questions and the use of language. So finding things that are in people's grasp. And when we were going back to co-producing leads, it's always a struggle to move people from the hierarchical to the networked, always a struggle from the simple to the complex. But I'm really heartened around primary care, because I think we've been doing a lot of work surfacing, you're turning people away and you're seeing the wrong people, and people are turning up frequently and you're not meeting them. And here is that picture of all those people bouncing around the system. So what's a better future for those? Because you're seeing them all the time and it's not working and you're really overworked. There's a sort of, it's like a cliffhanger, which is more of the same will not work and has not worked. We've been trying more of the same for a very long time. And our younger clinicians, they just sort of say, can we just try something else? And anyway, the nice thing about primary care is it's our business. It doesn't belong to the NHS. We're small and, so small and quite conformative and a little bit safe and not really market forces at all. But there's something about size. You put things in stretching distance. When we did Leeds has a very strong collaborative, it's a very strong identity as a city, but it's not too big. It's 700,000. It's not enormous. You could touch the sides of it. And people said, where will I find these folks who've got drug and alcohol problems? I said, well, you step over them in the street. Do you not talk to any of them? It's easy. So I think you have to make it so that it's reachable and not something so enormous. So the problem is, if you say the problem is, A&E attendance is through the roof, and we're dealing with people in corridors, and that feels huge to people. But then why don't we just let's try and work it out? There are some people in A&E who are coming from care homes all the time. Let's try them. What's the system for them? And make it understandable and reachable, and make it so that you can step into it. That's the only way I know to do it.
Yeah, it becomes too abstract otherwise, right? And I think that's great. That's really comes through in your whole presentation about your kind of practical take on this whole thing, right? And how this, and I think other people find that in other areas too, when they're really confronted with the problem, or they really take a practical approach, they see how complexity really helps them with that, because it's a very kind of natural, kind of organic way of dealing with the real world, right? As opposed to kind of bureaucracies and hierarchies that get quite separate from it and quite abstract and so forth. So there's
I think there's something about appealing to people about how they live their lives at home, because we don't live our lives at home like this. And so somehow we get into an organization, we drop everything we know about how do when you've got a problem at home, who do you call on, and how do you develop the networks and friends in order to be able to call on people at times of need? And that always requires reciprocity. And so I think, people will say that, like this work, we're hardwired for reciprocity. It's our human nature. So how do we appeal to that in organizations? And the difficulty is, as you landed on it originally, is that people don't get rewarded for reciprocity, they get rewarded for expertise. I think having skills in being able to collaborate and work with diverse folks is phenomenally important. and completely under recognized in the current system.
Mm. Well, that gets to the other, what you were getting to there at the end about going out like you did in Leeds and creating those spaces, those collaborative spaces where you bring different people in and talk to them, which is, I think, is exactly the way, I think, to deal with complex situations, isn't it? I mean, at the moment we're doing research into the idea of social labs. I don't know if you've heard of them, but it's exactly what you're doing. Basically, you're creating these, going out there and you're creating these spaces where you're trying to bring in all the different actors have an influence on that particular problem and trying to co-create the solution. And you put it well there. The systems leadership is about kind of creating those spaces, isn't it? And giving over that control to the people for them to, and valuing their input, right? That's another part of it, isn't it? Our traditional approach is the complete opposite of kind of pushing solutions out to people. Do you see?
It's a bit, it's back to the assets deficits model, that if people are deficits, back to the founding of the NHS and a lot of public services, people's problems have to be solved for them because they can't solve them themselves, rather than, and the narrative, well, we try and get people to solve their own problems, but they won't do it, and we're going to activate them. I mean, the language is appalling. Whereas an asset-based model, which is how do you start with where people are at? So, if any of you get to watch the end of that video, there's at the very end, a guy steps up onto the stage and he said to me, Becky, can I play that piano that's up on the stage, that grand piano? And I'm thinking, oh my God, I mean, it looks really expensive. I don't know what will happen. That's the worst that can happen. I don't think, what's the worst that can happen? I'm sure I can't damage that piano. So I thought, yeah, why not? Play us out. We're putting chairs away. And he was a concert pianist. He was a homeless, alcoholic concert pianist from Poland. It was heartbreaking. We were just crying. No one knew. No one knew, because what they saw was the homeless alcoholic from Poland who was, using public services. So, I always think that, people who, well, anyway, there's a lot of assets in people that we don't know about, and we have to start there.
For sure. We better wrap up now. We've just got one question I wanted to touch on there about value-based care, asking how do you see that kind of play into, a lot of people talk about that and integrated care. How do you see that playing into kind of the work that you do and the story that you're telling here? Is that part of it? Or?
I like Mike. We're talking about public value. I like Mike Moore's work on that. It's really great. Who can say, I always have that in the back of my head, who can say yes or no to what you're doing? And how do you generate work that's publicly valuable? So, I was sitting with some GPs the other day, and they had both stories in front of me. One was saying, do you know you're not providing any appointments to young people aren't turning up at your practice, but your job is to provide primary care services. He said, well, if they don't come to my practice for appointments, how can I provide services to them? And the others are going, oh my God, we should be going out and reaching out. And these dualities that people live with. And my payback was, well, what's your job? And what would the public say about the value you're generating if you think your job is just to provide appointments? Or is your job to go out and help people live better lives and provide primary care services? We had a real battle about that. So values-based conversations are really great ways to get into what's publicly valuable, what counts as value, who says, and who can say yes or no to what you want to do.